like to welcome you to Our Community, Our Health, a town hall series to share ideas about health, prevention, and treatments that impact our communities. Tonight's event is a focused discussion about treatments for COVID-19 in the outpatient setting, and specifically monoclonal antibody treatment for patients that are at risk for severe disease. My name is Duane Mitchell, and I will be your moderator for this evening. I am a professor in the Department of Neurosurgery at University of Florida and director of the UF Clinical and Translational Science Institute. Just by way of background, Our Community, Our Health is conducted by the University of Florida's Health Street program, which is located in the UF Department of Epidemiology, UF College of Medicine, UF College of Public Health and Health Professions, and is funded by the UF Clinical and Translational Science Institute. And so before we begin our event, I do want to discuss how you can become engaged in the conversation that we intend to have with the audience tonight. If you look at the lower portion of your screen, you should see a Q&A button that you can use to click and submit questions throughout the town hall. Someone will be monitoring the Q&A, the questions that are submitted via the Q&A function, and then we'll provide those questions to our panelists throughout the evening for a facilitated question and answer session. So we definitely encourage you to utilize that, and you will be able to hopefully answer as many questions as we can during the discussion session. We're joined by distinguished panelists who have great backgrounds in the care and treatment of patients with COVID-19. And I'd just like to take the time for them to introduce themselves. First, Dr. Nicole Iovine.
Hi, everyone. I'm an infectious disease specialist here at UF Health, and I'm also the chief hospital epidemiologist.
Dr. Cherabuddi.
Kartik Cherabuddi. I'm an infectious disease specialist, the director for the antimicrobial management program, and a hospital epidemiologist as well.
You have Dr. Michael Lauzardo.
Hi, everyone. I'm Dr. Michael Lauzardo. I'm a pulmonologist by training, but I'm the deputy director of the Emerging Pathogens Institute and the director of UF Health's Screen Test and Protect COVID-19 public health program on campus.
And Dr. Marie-Carmelle Elie.
Hi, I'm Dr. Elie. I am an associate professor in the Department of Emergency Medicine and in the Division of Multidisciplinary Critical Care Medicine. I'm also a director of Hospice and Palliative Medicine at UF.
All right. Well, I'd like to thank our panelists for joining us and look forward to exchanging valuable information to you who have joined us this evening, and also hope you will take advantage of their expertise to get your questions answered. And so now we'll begin our first segment, and that will be facilitated by Dr. Mike Lauzardo.
Great. Well, thank you, Duane. I appreciate the introduction and the opportunity to present this evening. So why are we here on a Friday night? Obviously, everyone's had a very busy, long week and working hard. And so why are we here? And you heard earlier, Dr. Mitchell refer to the fact that we're going to talk about monoclonal antibody therapy for COVID. And that's in fact what we're going to do. But I'm going to kind of push it a little bit and say that we're here to do far more than that. When we have gone through this pandemic and as we've continued to go through it, I don't think any of us have had a more frustrating time in our careers. Many of us are exhausted from working so hard, but the level of frustration, because many of us have felt powerless. You know, you hear the numbers, you hear the testing, a lot of the sort of challenges that we have as clinicians or public health spokesmen or whatever our role might be, to convince some people that this is even real when we know, in fact, that our hospitals are filling up with patients with COVID, trying to convince people they need to get tested. And all at the same time, we feel very frustrated because even those that do come into the hospital, or those that we can get access to, there's been very, very little that we have to offer them. In fact, we feel that, you know, getting them tested is quite an accomplishment. And in fact, our definition of success has changed so much. But I'm here to tell you that we're not powerless in all of this. And in fact, there's some great opportunities in that the monoclonal antibodies do provide us with a way where we can truly impact their care. And yet this remains one of the most underutilized tools at our disposal. For example, today I spent the whole day at a vaccine clinic that we're doing in the community. We're really excited about that. In fact, all that exhaustion I think that we're all kind of feeling is giving way to a lot of exhilaration. We're excited, we can fight back. But the reality is that what we did today in our clinic today and what you will be doing here shortly as we vaccinate more and more people is going to take months for us to realize the benefits from that, right? It's going to come, and the vaccines are way out of this mess. But there's something that we could do in the interim that we're really not taking full advantage of, and that's the use of monoclonal antibodies. So what we'd like to cover here today is that we're going to go over the data to kind of show you why this is going to be something that's really a game changer to prevent patients from going into the hospital and also even reduce the chance that they could die. And we'll go over that data with you here in more detail by my distinguished colleagues here on the panel tonight. But also just really want you to know again that sense of powerlessness that we have has to yield to the fact that we can get quite a bit done. Also remember that many of you serve under access to sort of rural populations. And when we look at outcomes, both anecdotally and the data supports the fact that these populations don't do as well. They may not have access to care with use of monoclonal antibodies, which are best given when given early in the course of the disease. And so you'll hear about systems that we've created to detect these folks early so that we can get them plugged into therapy early. And we're really looking at that, not necessarily that UF is kind of like this other entity that's out there, but really we're part of the community, part of your community, and a resource for you where we can work together to serve as one response for one community with one goal, and that is to prevent, the morbidity and mortality from COVID-19. Yes, there's a little bit of a light at the end of the tunnel with vaccines and a lot of heavy work to get there, but in the meantime, literally thousands and thousands of patients will be able to benefit from this underutilized therapy. And we're going to talk about how we can make that available to our patients and how you can play a critical role. So again, we're doing a lot more than just spending a Friday night learning about a new therapy. We're doing a lot more than just kind of getting our education up to speed. We're really changing the course where we really haven't been able to. We're really getting rid of that sense of powerlessness and really empowering not just us, but empowering our own patients. Again, we'll talk to you about what we've got in the works, what we're trying to make accessible for you and actually in turn for your patients. And we also want to kind of just remind you of the fact that, again, it's really easy to forget the fact that our patients really trust us. They trust you because that's who they go for their care, and they're going to trust what you tell them and what you'd like to guide them. So we want to arm you with the best information that you have. We're not trying to convince you to do one thing or another, but really to give you the information to make up your own mind, to just see that this is a way that's forward for your patients and a way for which you can feel gratified and feel like you can have a significant impact on the course of the pandemic. So really what we want to do is kind of talk about how we're making this accessible and also to start a conversation, to really not just kind of talk at you, but talk with you to see what your concerns are and outreach, what concerns might come up from this very conversation and how we can address those now as we continue to build the system to increase access to this really life-saving therapy that's going to have a significant impact. So again, with that, I'm going to stop at this point and introduce my colleague, Dr. Nicole Iovine, and she's going to talk to us now about kind of what's the current wave and get a little bit more background so we can put this conversation in context. So again, thank you for sharing your time with us. We know you're really busy and we want to make this as useful as we can. So again, thanks so very much. And Nicole, if you can go ahead and take it from here.
Great. Thank you so much, Dr. Lauzardo. I'm going to try to share my screen. Okay. Can you see my screen?
Yes.
You can. Wonderful. Okay. So my task is to talk about the current situation that we are in. And I think we all know that, we are struggling with cases, but I just wanted to show you because I feel like a visual is a useful thing. Okay. So one way to look at this is that we're in the third wave of this pandemic. These data are from the CDC, and they show that when we started out with this in March or April or so, we had our first bump. Then we had another bump over the summer, often following after some of the summer holidays. And now we're in by far the biggest surge right now. Some indication that it may be slowing down, but again, we are at a really, really high level right now. A disturbing trend here are the number of deaths. That's what's being shown here. And on this slide, you can see that we have more people dying of this disease than ever. And the numbers are still look like they're going up. So we really have a lot to do, have a lot of work to do here. Looking just at Florida now, This is a map that's on the Florida website, but this is showing the rates as opposed to the absolute numbers. I'm showing you the rates of infection. It's a different kind of way of looking at this, but I think it's really important. So the overall positive rate in the whole state of Florida has been about 7.7%. You can see our total cases are really high at almost 1.7 million. We are definitely on track to hit 2 million, unfortunately. But if we look here at the individual counties, you can see that the dark brown ones are certainly suffering. They're especially hard hit counties. So Lafayette has a positivity rate of over 17%. Suwannee is nearly at 11. Columbia is over 10%. Union is approaching 11, and Bradford is almost 10% as well. This is really, really a very serious situation, certainly for our patients who are in these and other similar areas in Florida. Something that's been very clear, and I'm sure you're aware of this, is that older patients are at more risk. But these data I thought were interesting because it really drives the issue home. And again, this is taken from the CDC, so these are national data. And I kind of grouped it into under 65 and over 65. So in the under 65 group, you can see all the breakdown of the various age groups here. And young people really are not, by and large, dying from this disease. Yes, many people are getting sick, but they recover. We start to see a big jump in mortality, starting with this over 50 age group here in green. But again, you can see that on the bar graph on the right, as people become older, they account for a greater and greater fraction of patients who do not survive. So the over 65 to 74-year-olds, 1/5 of them are dying, and about 1/3 of people that are over 75 are dying of COVID. So just a word about the variant strains. Probably you've been hearing about these. And this is something we need to pay attention to as well. The first variant that was detected was in the UK, and it was notable because this variant was more transmissible than the usual strains. Fortunately, it seems to cause, it does not seem to cause an increased severity of disease. And also our preliminary evidence suggests that it is more effective. However, the US cases that we've seen here are generally not connected to international travel. In Florida, we've had 96 cases that have been confirmed by the CDC. California has had a significant number. However, it's very likely, and I'm about as sure as I am of anything, that the actual numbers of this variant are a lot higher. Because it takes a more intense effort to detect these variants, because you have to actually do gene sequencing to determine if it is the variant. But nonetheless, this is a big concern because, you know, obviously if it's more transmissible, we can expect more infections. And the big concern is that this could lead to a fourth surge in infections. There is another variant that we've been hearing a lot about. It was identified in South Africa, and it's been identified now in 2 persons in South Carolina. All the other states that are colored in here have the UK variant that I just mentioned, but clearly this South African variant is here in the United States. Again, no link to international travel, suggesting that, you know, this is circulating in the community. In addition to being more transmissible, it seems to just have a normal disease severity. But one concern, and we don't have a clear answer on this yet, is that it's possible that this particular strain might not be as easily neutralized by vaccination compared to the usual strains. It's not confirmed yet, but it is a concern. So for all of these reasons, the people with limited access to care, people who are over 65, the concern about these variants, it's extremely important that we do everything we can to bring the best treatment to these patients, and that's why we are all here today. With that, I will pass this over to my esteemed colleague, Dr. Elie.
So thank you so much for that presentation, Dr. Iovine. So to dovetail on the importance of finding appropriate treatments and reducing the number of patients that are suffering from COVID-19 right now, one thing that we have to point out is that the deaths are frequently associated with increased hospitalizations. And the pressure being placed on the healthcare system currently, especially in hospitals, is limiting resources that would otherwise be provided for patients that suffer from a number of other non-COVID related conditions. So in addition to making sure that we can eradicate COVID-19, we are really trying to prevent hospitalizations at all costs. Becoming hospitalized from COVID-19 is an important inflection point when developing the disease. Because we understand that while therapies do exist, many of them are not as effective as perhaps we would like. And we don't have a silver bullet for this yet. And so while we do the best that we can in the hospital to support patients, most of the care is very difficult. It's very difficult to reverse most of the disease and the complications that many patients succumb to as a result of COVID-19. And so the key is to identify treatments and to attempt to treat patients as early as possible upstream of them becoming hospitalized. So with that, I will turn it over to my colleague, Dr. Cherabuddi, who will be talking about some of those treatments that we believe are going to be key in not only eradicating the disease, but in preventing hospitalizations.
Good evening, everyone. I'm going to talk about COVID-19 therapeutics. Broadly, I would classify them as these 4 categories, and as this continuum, the vaccine to prevent infection, antibody treatments to prevent people from getting more severely ill, and antiviral therapies as well to prevent more people from getting more severely ill, preventing death, and immunomodulators do the same, prevent worsening in death. And there's sort of this continuum from vaccine to antibody treatment to antivirals and immunomodulators. Are you able to see my screen okay? Sorry, I just got a pop-up. So the way to think about it from clinical illness would be to look at the phases of clinical illness. People may have only asymptomatic disease and not progress further. It could have the viral phase of disease and then stop there, or you can then prolong into an immune phase of disease. This is where people tend to get more severely ill. Most ICU hospitalizations happen here. Death tends to happen out here as well. And then some of these folks, whether through the viral phase or those who pass through the immune phase, also have late sequelae of disease. When you look at the therapeutics and where they should act, most of the early therapeutics are out of the hospital. The vaccinations, the antibody treatments. We don't yet have an antiviral compound that's outpatient, but that would be helpful. Our antiviral and immunomodulatory agents that are approved tend to be in the hospital. For late sequelae, there's no known treatment. The monoclonal antibodies cocktails essentially are 2 of them. Lanevamap or BAMLAN, as some people call it. The Regeneron cocktail includes 2 different antibodies. They're essentially this equivalent in their effects. There's very little that separates them in side effect profile or therapeutic action. I would think of them more interchangeably. Convalescent plasma or high titer plasma, also an antibody treatment. It's EUA approved. In my opinion, the monoclonal antibodies have better efficacy. When you look at the study data and real world data, bears that out as well. Remdesivir is the intravenous antiviral compound that Dr. Iovine and Dr. Elie have contributed to to its use by participating in the ACT trials, as well as two compounds that are immunomodulatory compounds. Dexamethasone, which has been shown through the study in the UK to have mortality benefit, and then baricitinib, which again, Dr. Iovine and Dr. Elie have studied in combination with remdesivir as immunomodulatory agents. Again, the antivirals, immunomodulatory agents tend to be in the hospital. What we really want to do is use therapeutics that prevent people from getting hospitalized. And therefore, the stress in this talk is starting with the vaccine itself and then looking at antibody treatments. Try to use these antibody treatments outside the hospital so we can prevent folks from getting severe illness and hospitalization. The vaccine is pre-infection. It can prevent all these phases. The antibody treatments, you want to use as early as possible in the viral phase of illness. So as soon as symptoms start would be ideal. And they could potentially prevent you from going into the later stages of illness if you use them early in the viral phase. Antiviral therapies, again, are in the viral phase, and they could prevent further worsening. Immunomodulators are only in the hospital and given in the immune phase. Looking at, I'm going to talk about one of the compounds, and like I said, they're sort of interchangeable in that way. The bamlanivimab has one antibody, the Regeneron one has two different antibodies. They basically bind to the spike protein of the virus and prevent it from causing all the effects it does. We all know now that the spike protein is key in the pathogenesis, and these antibodies target it by going ahead and binding to it. So you're providing passive immunity to the patient before they've had a chance to even build their own antibodies or augment their own antibody response. It's not FDA approved, but it's EUA authorized to use in outpatient settings in mild to moderate COVID. It can be used in adult and pediatric patients who have a positive viral test. It requires that the patients are at least 12 years of age and more than 40 kgs. And really the value is in targeting those who are at high risk for progressing to severe COVID. The FDA recommends giving the drug in the first 10 days of symptom onset, but when we look at the study, most people were given the drug in 4 days of symptom onset. So ideally, it's 72 hours of illness, or at least within 5 days of onset of symptoms would be the best one. And if you look at this little schema here, we know that the virus goes up very quickly in the 2 days prior to symptom onset, and then sort of falls very rapidly down. And that's why using this agent, which binds up the viral proteins, it is key that we give this early. And in a way to think about it is, even when you're ordering the test for the patient, if they meet the criteria for the drug, sort of the discussion starts then. It's not authorized to give patients who are hospitalized due to COVID-19, who are symptomatic from it, or who require oxygen therapy due to COVID-19. I think it's too late by then. They're in the later stages of illness. And also in those who have a chronic baseline oxygen and now have an increased oxygen use. So we should not use it in these patients. The data comes from the BLAZE-1 trial. I'll show you those data very quickly. Bamlanivimab comes as an infusion. It's 700 milligrams and 200 ml normal saline. You don't require dose adjustments for your patients who have renal or hepatic dysfunction, which is very helpful. It comes in this vial and it must be reconstituted. And the pharmacy can do this fairly easily. It allows to be stored and administered within 24 hours. So it does give us time to prepare for the next day and so on for these infusions. Patients are to be observed for an hour following infusion. This is key. This is part of the EUA, that we must give this infusion in an hour and that the patients be monitored for at least an hour following the infusion. Infusion-related reactions were low in the study, and real-life data shows that they're quite low as well. So this is the evidence. The key part I would want you to look at in this study is the number needed to treat. Essentially, how many people should you treat with this infusion to prevent one hospitalization or ED visit? If you look at all people enrolled in the study, it's about 21 people that you need to treat to prevent one hospitalization or ED visit. But when you look at those who are in these groups that we're trying to target, those above age 65 and above, or those who have a BMI 35 and above, you need to treat 10 people to prevent one hospitalization. Like I said, the side effects were very low. The severe ones we're looking at were sort of more abdominal pain and things like that. There's one anaphylaxis reported in another study done with the same product. But that's why the monitoring is important, and the centers are prepared for anaphylaxis, just like they are prepared when we administer vaccine. So what does the real life experience show us? There are a few centers that have used it quite a bit. They found that the infusion is quite safe and the reactions are quite low. This product is quite underutilized, like Dr. Lauzardo was saying. The initial logistics of setup can be difficult. I think this is a challenge that many centers have faced, including us. Some centers, once they have these initial setup placed, been able to ramp up quite a lot in how many infusions they're able to do. From these centers, we're learning that the rate of hospitalizations is only about 4 to 5 per 1,000 infusions, which is great. Sorry, that's more 4 to 5 per 100 infusions, which is great. Steps for you to do, think of this practically: confirm that the patient is mild to moderate COVID, is within 10 days of symptom onset, meets those age and weight parameters, and then look at, do they meet the criteria specified in the EUA? Do they have a BMI that's 35 or above? Do they have chronic kidney disease, diabetes, are on immunosuppressive disease or receiving immunosuppressive treatment? Are they 65 or older? These are pretty straightforward. If someone is 55 or older, then do they have one of these other risk factors such as COPD, cardiovascular disease, or hypertension? For pediatric patients, there are additional criteria. In the interest of time, I've not listed them, but they're clearly available in the EUA, and they specify which groups are at high risk. So how do you find a center close to you? This is a good website to look at. If you Google HHS and therapeutics locator, you'll find the locations. You can pick your location in the radius, and then you can look up what's available in Florida around you. If you have to get closer, put in Gainesville, and these are all the areas close to Gainesville, and these come up. So you our center, the Shands Teaching Hospital and Clinics. There's a couple in Lake Butler, 3 in Ocala, 1 in Lake City. These are the ones immediately surrounding us. I've worked with a couple of these locations, and I know they've been doing a good job in getting infusions done. One's in Ocala and also in Lake City. And we have infused quite a few patients as well. I'll stop here. I'll hand over to Dr. Mitchell to answer some questions if you have any in the chat, and then we'll also tag team on a couple of additional issues.
First, I want to thank all of our panelists, really outstanding information, and I'm just going to touch base briefly on some of the efforts that we at UF Health are engaged in trying to enhance availability, access, and uptake of the monoclonal antibody treatments for COVID patients that are at risk. The Health and Human Services is really trying to work with institutions to increase awareness. So this forum itself designed to just increase provider awareness about the treatment and the indications, and how to gain access, as we've discussed here this evening. We will be following up actually with a similar information session, but targeted towards the lay public and as well as embedded community leaders and healthcare workers who are familiar, have trust with the patients in the community, and can also be a conduit for information and helping link those in need to care opportunities. And then at our own, we are also continuing to work on expanding capacity and access to monoclonal antibody treatment, including the operationalization of a mobile clinic that may be able to provide care closer to where patients live. And these are all efforts that are underway, and in the coming weeks will be information resources as well as potential access points for additional therapeutics. So I'd like to, again, thank our panelists. And now I'm going to turn to our moderators who have been looking at the questions as they've been submitted. And we'll read those questions out, and I'll direct them, we could direct them to given providers to answer.
Okay. I'll ask the first question to you. Is the treatment the same as treatment that uses the donated plasma of people who recovered from COVID?
And Dr.
In
Cherabuddi?
some ways, it is similar in that they're both antibodies. And when we're using the plasma from people who've recovered from COVID-19, there can be multiple kinds of antibodies. Some of them might neutralize the virus, but a few of those might not be able to do that. And again, there's a variation in how much antibody is present in each of these infusions. Whereas when you use this product with the monoclonal antibody, you have one kind, and that's why it's called monoclonal, one kind of antibody that targets this spike protein, and you have a certain amount of antibody as well, because it's like any other medication. It has a dose and it has the amount of antibody in there. So it's in that way, it's more reliable. It's the same product, if you will. Whereas with convalescent plasma, you could have variation on the kinds of antibodies and their effectiveness against the virus. I hope that answers it. They're similar in some ways, but also dissimilar in other ways.
Thank you very much, sir. Our next question, we'll target this one to Dr. Iovine. Is the new variant of the virus known to cause more severe symptoms than the one that has been targeted with the current vaccine?
Dr. Iovine?
Sorry, I don't know, my video for some reason won't go on, but I hope you can hear me. You can hear me? Okay. So no, there is no, we don't have any evidence that the variants cause more severe disease. Right now, what the information we have is that it causes the same level of disease as the usual variants. Are the participants able to see the answers in the chat that we've panelists have replied to?
Yes, they should be.
Oh, they can. Good. Just wanted to make sure.
But we should assume maybe they can't. So, yeah.
So an open question that's still there, and they're actually closely related. And I'm not sure who this question is for, but how affordable is the treatment? Who's paying for it? What's the cost? This is just something that kind of is recognized from there. I don't know if there's someone that can speak to anything about that in terms of affordability.
Either Dr. Iovine or Dr. Cherabuddi like to take that, or Dr. Elie?
So right now, I'll go for this. Right now, it's free for the patient as well as the hospital. There's no charge to it. The federal government has been able to purchase it from the drug companies and make it available to institutions for use in patients. And there's a lot of product that's yet unused. So for quite some time into the future, we'll be using up that product. So there shouldn't be a cost for it. The only charge, if you will, is for the administration itself, and you can bill that to the insurance whether it's to Medicare or charge that you can also apply to other private insurances. But the patient should not receive a bill for it.
Yeah, I think that's a really important point that, shouldn't be a financial barrier at all to trying to link patients to care. Monoclonal antibodies are typically very expensive treatments, but these have actually been purchased by the government and distributed so that they can be made available free to treat patients.
There was another question that was answered in the chat, but the question was, can the infusion be administered at home? Dr. Ivy.
Not at this time, and I don't know if Dr. Cherabuddi wants to chime in, but it's required that there is a observation period afterwards to make sure that there aren't any allergic or other reactions. So it's not administered at home right now.
We have some additional open questions, if I could, please. The first one is, how do I talk about the need for speedy infusion with someone who is positive?
So,
Yeah, well, Dr.
Go ahead, Dr. Elie.
no, actually, I was just going to dovetail on what Dr. Cherabuddi had mentioned a little earlier. One of the most important aspects of this infusion is that it has been shown to reduce the ability for the virus to replicate over time, and has been shown to reduce the need for hospitalizations. And this is just in early studies, and anecdotally, in other cities where they are providing these infusions to patients, we found that hospitalization rates have declined because of the utilization of this drug. And so that would probably be the most, probably one of the most effective ways to encourage someone to have this infusion is to tell them that it does reduce the likelihood of being admitted to the hospital, which, as I mentioned earlier, presents a huge inflection point in health once, if you have COVID-19, once you have to be in the hospital.
Okay, there's a question about a third wave. Dr. Iovine, any idea how many waves there could be and what do you expect?
Oh boy, I really hope this is the last one. It's really hard to say. There's all models out there about what will happen, but there's always seems to be a wild card in there that we can't necessarily predict or model very well. Again, many of us have concerns about a highly transmissible variant triggering another wave. We hope that's not the case. We hope that if people get treated quickly and if people get their vaccine, that won't happen. But if there's one thing this pandemic has taught us is that, our predictions are not always correct.
Very good. We have a logistics related question here. Are surrounding community providers able to order BAM to be infused at the UF clinic? And if so, do they just write a script?
Perhaps Dr. Cherabuddi could take that.
We're ramping up our ability to do this now. We've certainly seen interest from the community providers, and we've heard it. We're right now in the process of providing more infusion chairs and also having an intake mechanism. So more to come. We're almost there. I think in the next few days, we'll send out information on how to contact us and how we can help you order this drug for your patients. There are some flyers we have, and Dr. Mitchell can mention that, which also includes our contact numbers and also information on how to talk to your patient about the drug, but also how to refer to infusion here.
There's another question here about, do we understand why the effect of this is so much better for people who are older and have higher BMI?
Yeah, I'll direct that to Dr. Cherabuddi as well, because
I think in some ways, if you look at, it's not that it's more beneficial in this group. The way I would think about it is, these are the risk, these very factors make it more that you're more likely to have more severe illness. So if you're older, you're much more likely to have severe illness, to be hospitalized, and even to die from this. Or if you have a higher BMI, you're more likely to get hospitalized with COVID. And therefore, the gain is higher in the same groups who have a higher risk for getting hospitalized. I think that's the best I can read from the study. The higher your risk is for having more severe disease, the likely higher benefit you have from the infusion.
I'm picking a theme here for the questions, as we can see. We've seen reduced and not increased access to healthcare in some of the rural communities. Can things like new mobile clinic vans be used to deliver infusions? Is that a possibility?
Sounds like you, Dr. Mitchell.
Sure, I could take that. So it's a great question, and yes, our intention in the utilization of the mobile clinic is to actually be able to perform infusions, regionally close to where patients live, and to provide better access. This was one of the specific objectives that HHS engaged us at UF Health to work with in terms of increasing access. And so we'll provide, I realize it was not on video there, apologies about that. We'll provide additional information as to as that service comes online. And, we're also in conversations with the Department of Health. Dr. Lauzardo has had a really integrated relationship with the Department of Health throughout the course of the pandemic. And he may want to speak to that and add some additional details about utilizing some of the capabilities of testing and trying to get patients linked as early as possible to treatment. So I don't know if Dr. Lauzardo, if you'd like to add any context.
Yeah, just real quickly that kind of one of the key things is early initiation of therapy, which makes it more effective. And so because of as Dr. Mitchell said, how integrated we are with the Department of Health with our Screen Test and Protect program and other relationships, we've been working with them to be able to identify patients as soon as they have a positive test. We can contact them, ask them to get in touch with their provider, and then coordinate care at that moment to get them plugged in as soon as possible. Again, the key there is not to bring them down to here, which somewhat defeats the purpose. The goal there is to make sure that they have places where the infusion can be done locally. And really the key thing is for them to get access to begin with, and that early access is critical.
Thank you.
There's an interesting question here. It said, this is an amazing treatment. Is this information being shared with everyone who tests positive?
Why don't we ask, I'll direct that to if Dr. Iovine and Cherabuddi and or Dr. Elie like to some comments along the information dissemination.
I can take it first.
Yeah,
we're not, as a medical community, not doing a great job of spreading this information. I think it's twofold. When we first looked at the data itself from the study, when you look at the differences in numbers, it didn't seem as strong. And then the biggest factor was, how do we get this done in a patient who's probably most infectious in an outpatient basis, right? Do we do this in the emergency rooms, which are already full, since we are facing the surge? Do we do this in our infusion centers where we have cancer patients and so on? And how can we do this safely? I think many institutions around the country sort of struggle with how do we operationalize this, giving this infusion. There are a few places that have tried to give it in their dialysis centers. So people have gotten creative. We've tried to administer it in one part of our infusion center, sort of separated from the other patients, keeping them safe, having a process to get them in, but also meant that we could only take on a couple of patients at a time. We've tried to look at when is our emergency room least busy, could be early mornings. So we try to give infusions early in the morning in the emergency room. We've sort of been able to use those spaces and be able to administer the drug. But as we've seen real life data, I think many institutions are trying to ramp up this effort and trying to see if you can do this in additional spaces. So it's been a challenge of, if you spread the word, are we able to take on all the infusions, right? We're letting everyone know this is an infusion that's available, but also is it truly available when you want it, right? We want to be able to take on and administer the drug as much. So it's sort of caught in between. I think we've learned as a country that there are other ways to do this, and learning from centers that have done this successfully. I think over the next month, we'll see much more availability, especially at UF, but other centers as well. So we want to also start talking to patients as the test is ordered, when they get positive, to say whether they qualify or not and how they can get the infusion.
There's another question here. People are afraid of getting tested for many reasons, including that they won't be able to go back to work and they need to get tested first. Any thoughts on how to communicate the benefits of testing in our communities?
I think I'll ask Dr. Lauzardo to take this question.
Yeah, so that's the $1 million question. I mean, I think that I think that just appeal to people's altruism, first of all, and that they're not doing it just for themselves, but for their loved ones. Usually it's those who don't have risk factors, that don't want to get tested, that are kind of the walking, talking well, that can go to work, but don't want the inconvenience of being isolated if they're found to be asymptomatically positive. But the key there is that just knowing about their loved ones, appealing to the fact that they can transmit it to someone that they love unknowingly who does have risk factors. I think that's an important part. Also, I think there's the fact that the ease of which testing is done is also helpful, and how it's much more accessible than it was previously. In Gainesville, we do have access to saliva-based testing, so that's kind of reduced some of the sort of invasive nature of the nasopharyngeal swab. But many labs have also validated just a nary swab, so just a bilateral nary swab, and it doesn't have to be all the way a deep nasal swab, depending on the lab and who's doing the testing. So I think the biggest thing that we found to be helpful is appealing to the sort of altruistic nature when it's done on an individual basis. I think institutions and practices can kind of institute their own testing regimes to make sure that people stay safe, and kind of have it be policy for institutions and larger groups to kind of encourage compliance, if you will, with testing. Testing really gives us eyes to see. It doesn't really necessarily increase the number of cases, right? You detect more, but really they're there anyway. The goal here is to identify things we can appropriately isolate and quarantine those individuals and get them in place where they need to be so that they don't continue to spread.
Very good. A next question we have that goes very deep. What can we learn from this current pandemic with respect to preventing future pandemics in the best case, or minimizing the impact the next time we're in a situation like this? I myself love to hear your answers on this question.
I think we're all going to have opinions on that one. So
why don't we start with our Chief Epidemiology Officer, Dr.
You know, there is just so much to say about that. There's so much, but I think the first and foremost thing is that we really need greater support for our public health infrastructure, because they're the ones who, that's what they're here for, to respond to these sorts of things. So having a robust and organized and concerted effort in that regard, I think is really just the foundation. I see Dr. Lauzardo nodding. I knew he would like that answer as well.
Yeah, absolutely. I think that, again, that public health infrastructure, but I'll even go sort of one step earlier than that. A key thing, I'd be very happy if we didn't throw out our pandemic preparation plan. What most people don't know is that, right, I think it started sometime in early 2019 and ended, I think, in August of last year, or 2019, was something called Crimson Contagion. And Crimson Contagion was an exercise across multiple government agencies that, get this, look to see what the response would be for an outbreak of bird flu coming out of China, and what would be the world response. And exactly all the things that we've had to deal with: PCR capability, lack of supplies like swabs, PPE, the development of a vaccine, vaccine hesitancy, new therapies and approving them quickly. All of these things were known before and actually came out during the exercise, and there were plans to deal with all of these. So again, I very much applaud the idea of public health sort of investment, right? So it's just, this is the reason why all of us woke up this morning and didn't thank anybody. We got cholera, right? Because we have a health department and health system that works. And so it protects us, but we forget about it when we don't put it into context. But really, I'd be very happy if we just didn't throw away the plan that we had. And because if we had used the lockdown to address the things that were identified that we knew would be issues, and not got people into thinking that we're sort of in a kind of do or die, right? So you're a good person if you approve lockdown, and you're a bad person if you think of open. We got people thinking in a polarized fashion, which is kind of the norm now in our country and in our culture. But the reality is that staying closed was never an option. When you look at lockdown, lockdown is bad. You know, not only did we have, 300,000 deaths before the end of 2020 or over that, there was 100,000 other excess deaths that were identified. And those were from people not going to the emergency room when they needed to, people not seeking medical care because of fear of the COVID, the effects of the lockdown, unemployment, suicide, substance abuse. I could go on and on and on in this sort of tragedy of what's happened. And a lot of that was because many of those things were avoidable. I mean, they were things that we could have done differently and done better. So I think that listening to the experts, listening to the science, listening to the data that we've got, and use the plans that exist, I mean, is step one. And then investing in public health, as Dr. Iovine mentioned, because I think you've got the key thing that we're struggling with at the moment is that the US is, I think by some accounts, 43rd in our ability to sequence pathogens to identify whether or not there's new variants and what they really mean. 43rd, we're not sequencing anything. Well, we are, but no, proportionally so much less than our peer countries. So all these things add up to really kind of take away our eyes and take away our ability to truly respond to the pandemic in the right way. Sorry, I got on my little soapbox.
Great, thank you. No,
a little bit of a sensitive topic for all of us, I think.
You haven't thought about this at all.
No, not at all. Not at all. Just,
if we'd like to have any brief additional comments from Dr. Cherabuddi or Dr. Elie, and then we will move to our next segment. But anything to add in terms of general preparation or things we'd like to do differently should we face this again?
Yeah, I just want to echo what Dr. Lauzardo said. Even more upstream is just we need to make sure that there's an international policy so that we're constantly communicating with other nations about what they're seeing and their trends. As stated, there was a plan. We knew that a pandemic was coming, and most of those plans were deconstructed in the years before, or the year before actually this happened. And if we had some of those plans in place, in many ways, I think that some of this could have been avoided.
Any additional comments, Dr. Cherabuddi?
The only thing I would add is we've learned the importance of clear communication, strong central communication, and that communication can change over time, but the clarity is important. I think that's the biggest thing we've learned.
Well, I'd like to really thank the panelists for their information, and also most importantly, the participants really for the very thoughtful and important questions. We are going to now, I'm going to turn it over to Dr. Mike Gutter, who is going to engage our audience. We'd also like to learn from you and learn with you. And so I will turn it over to Dr. Gutter for this next segment.
Thank you very much, Dr. Mitchell. And I hope you've all have learned a lot this evening. It's really always a pleasure and an honor to get a chance to present with some of these folks here. And it's really, they do a really great job of helping to break down some of these things. My name is Mike Gutter. I'm Associate Dean for Cooperative Extension here at the University of Florida over in IFAS. And I work in the areas of, youth development, but also in the areas of communicating public health. As you know, one of the things we try and do is be a strong partner for all of this. And one of the things we'd like to do is make sure that we can keep the conversation going together. And in order to do that, we want to continue to hear from you. There's a few questions we haven't had a chance to get to tonight, and we're going to work on those, but we also want to invite you to submit additional questions you may have had. Tonight, we focused on monoclonal antibodies, but we're able to talk about other things, but there may be additional questions that you and your patients still have about COVID-19. There's amazing experts here at the University of Florida who are happy to try and work with you on that. So if you're able to go to menti.com on your phone or in your web browser on your computer, you're going to be asked for a code when you go there. And that code is 377709. I'll say that again, menti.com. The code is 377709. We're going to ask you about two things in particular that we'd love your feedback on, and that is, again, additional questions you and your patients have about COVID, and you'll be able to enter those right in for us. And then have you been able to make referrals for monoclonal antibodies so far in terms of that treatment for COVID-19? So again, I hope you'll have a chance to continue to do that. The site will be accessible for several days. So we will make sure to check those, and then we will work together to get back in touch with all of you who have been here tonight so we can have that. I want to also share that we have a partner that we're here to be a partner. And so together, University of Florida Health has worked with some of our colleagues in cooperative extension, including Haley Corbett, who's your local Columbia County extension agent who visited some of your offices, to have some posters available that help you understand about monoclonal antibody treatments, specifically posters potentially to help you think about your own eligibility issues for patients. Also a poster that's available to help a patient understand what is monoclonal antibody. As we've said, breaking down the mysteries of some of these things can be very important for uptake. Additional handouts that are available, treating patients for COVID-19, as well as some basic answers that patient questions might have. What are they and are they safe? How can this treatment help me? Is this the vaccine? How will I receive this? Is it a pill? And how much will it cost? We know these are some of the critical patients that patients have, and we've tried to make sure that we had ready-made answers available for you should they come up. As you've heard tonight, rapid response is certainly a part of this in terms of that, and so we want to make sure that we can demystify it for anyone necessary. Lastly, we have some patient handouts available for you all. And those are something that can be available. It's small and very handy, about half the size that you would see, and front and back. And again, it's a basic that they can have. This is something that if they're going to be going on to treatment, as the referral system is able to be perfected, again, this is the type of thing that, maybe something they can take with them to help them kind of remind them what they're going to be about. So I want to go back and just make sure that you all have the link. I do see some questions coming in, and as we've said, we'll make sure that we get back to those for you. That link will be available, and I'll, as I've said, one of the things I want to mention is we are a partner for you. As you've seen here, the researchers here and clinicians at University of Florida Health and are here to help provide some of that education. And in your counties and every one of your counties, cooperative extension is there to hopefully provide some local support in terms of educating your community and helping to bridge those gaps. So I'm going to turn this back over to you, Dr. Mitchell, and we will go from there.
Well, again, I want to thank you, Dr. Gunner, and thank you to all of our panelists. Thank you to the participants for their engagement. This concludes our Community, Our Health this evening. We're really glad that you joined us for this town hall event to discuss this new therapy and therapeutic options for COVID-positive patients. We will be in touch with you with additional information. Some of that is already in your inbox, and as Dr. Gutter mentioned, look forward to staying engaged with you in terms of answering any additional questions, as well as informing you with additional forums and with both yourself and your patients can get more information on vaccines and treatment for COVID-19. So have a good evening and a good weekend. Thank you.